My dear friends, it's a very interesting session because it's a practical session. And you have in front of you the people who had been practicing diabetes for years, and they will give us their wisdom, which is very important. So this is a meeting which is about the sharing information from the experts. It's a very interesting session, and I must assure you that we will not exceed time, and we will try to complete it within the time given to us. So the title of the session, how do you choose the best regimen for your patient? How do you choose the best regimen for patient? So if there is quietude, we'll start the session right away. And we have four authorities in the field. We have my dear friend Ram, needs no introduction. Then we have Professor Venkatraman, same. He's well known here. Aishar Arvind is absolutely known across the country and beyond. And Professor Hariharan is my close friend, and he needs also any introduction he doesn't need. Dear friends, we'll just start. The session is a free session in the sense that the people who are speaking can speak at any time when I ask some questions, because they will give the wisdom, but it has to be a little short so that we give adequate time. Number two, we'll be leaving behind at least 5 to 7 minutes for you people to ask questions to these experts. They call it roast the experts. They roast them well so that they become even more tagda. And we'll start right away. Ram, I just start with you. We have not rehearsed because we thought this session must be absolutely ex-tempo and without any rehearsal. So my question to you, Ram, is what do you find? What are the foundational requirements for your patients? Foundational, beyond drugs, what you advise?
You should listen to my talk, which I just gave.
I was
talking about...
many of the things, I must admit, what is spoken today must have been spoken earlier in the sessions. No, but that doesn't matter. Yes.
Yeah, we're talking about type 2 diabetes, which is a lifetime disorder. So we're going to accept the facts about life. And as we've been discussing about, we do not treat a condition, we treat a person with a condition. So therefore, we must know that the priorities in life for that person may be very different. When you see somebody with a blood sugar, high cholesterol, blood pressure, or we keep writing the medicines for them for blood pressure, diabetes, and tell about the diet. But you must also understand they themselves have their priorities, fundamentals, which you said, which have to be addressed. You have to talk to them. Please do one thing, listen to the patient and find out what are his anxieties and problems. Then only you write, because you're not treating fever, you're not treating hypoglycemia, you're not treating myocardial infarction. You're treating a chronic disorder. A person sitting in front of you is an asymptomatic individual with diabetes, blood pressure, high cholesterol. So the fundamentals are there. Please listen to them and then discuss what you can do for the patient for the next many years to come. Many years to come.
I think that's a very important thing Ram has said. What is very important is every patient is different, and foundation of the treatment starts when you listen to the patient and you identify this particular space that all of us have individual spaces in treatment, what space he takes. Hari, can you tell us about your opinion on the LSM, the foundational treatment with exercise, behavioral treatment, sleep? What do you do? Very brief.
Well, we have done randomized controlled trials with LSM on primary prevention. And as you know, for the lifestyle modification, there are two axes. One is diet and the other one is physical activity. Now, in all the four trials, we did a meta-analysis to find out which component of that lifestyle modification is more acceptable to the patients. Fortunately or unfortunately, what we found was diet was effective. People were able to reduce their amount of sugar and sweets, amount of carbohydrate, the total fat. But it was very difficult to make our Indians do exercise. I don't know why. That is a problem that we found. That is the only thing which of course, some of us are addicted to exercise. For example, Arvind, myself, Venkatraman, all four of us walk every day 20 to 30 minutes. If you don't do that, you don't get your breakfast.
Well, I think so.
So I used to tell, I used to tell my patients that,
Yeah.
I know, wife will be sitting there, okay, he has to walk every day 20 to 30 minutes. If he doesn't do that, you don't get your breakfast.
Fine. Hari, what do you think the first line of pharmacotherapy? In your practice, first line, the first drug in the pharmacotherapy.
You see, Ashok is asking like a Viva OC for an MD examination.
No.
He never told us the questions. He never told us the questions.
See, Ashok is asking like examiner.
Examination. MD exam.
But Ramchandran is answering the best of the student in the class.
Good. Please enjoy this. Hari?
Yes, first line drug. Right today, every drug that is enlisted in the pharmacopoeia is a first line drug, if you really ask me. So you will have to choose with the one you want for a particular individual that is with you. So you cannot really say which drug is the first line drug.
Correct. Arvind, having said that, what drug you will prefer in the first line?
I just want to add that, okay. After 50 years of treating diabetes, when a patient is sitting in front of you, I want to just share it. I will never know which is the drug which will actually bring down his blood sugar. Whether it is sulfonyl inhibitor, metformin combination, is he really, metformin sometimes will not be so I am not sure which drug. So only by giving it, seeing the response, you can decide which drug you can continue to give to the patient. I mean, okay, you can answer.
Correct.
See, one of the things that we do is try to find out what are the activities of that particular individual. It can be a driver who cannot eat on time. It can be a pilot whose timings are really messed up in life, or it can be a very elderly person staying alone. So basically, if it is no hypo, no weight gain, probably still there is a role for DPP-4 and metformin. But if you are really looking into the guidelines, cardiometabolic benefits, I think SGLT2 becomes the first drug. Because people will definitely not take a GLP-1 straight away yet. So I think an SGLT2 with a metformin, making sure that a male patient does not have phimosis and balanitis, because that's become a part of the examination now. Genital hygiene is taught. Today's world, cardiometabolic benefits, probably SGLT2
Absolutely correct,
metformin would
absolutely
be my first
Correct.
drug. Okay, if there's no contraindication to that.
Venki, I'd like to ask you how often you start your treatment with a combination, like let us say about dual combination.
Thank you, Professor Ashok, and thanks, friends. And I think the platform has been nicely set. I think before we go on to the molecules, what is it that you want to achieve in the patient in front of you?
Correct.
Number one, normalize the glycemia as early as possible. Do it with minimal side effects. Accommodate the molecules which have extra glycemic benefits.
Like comorbidities, as Arvind pointed out. Yes.
That's
correct.
number one. Then number two, monotherapy has to be abandoned in my opinion, because you have molecules which have the potential to push the HbA1c beyond 6.5, 6 and even 5.5, and if you can achieve it without the risk of hypoglycemia and weight gain, why not? So combination therapy should be the order for all type 2 diabetic patients. In this scenario, there are three players: metformin, SGLT2 and DPP-4. Of course, verified trial gives you the evidence
Metformin,
that
DPP-4.
combination therapy is superior to monotherapy. That's number one. And number two, in clinical practice, I think having learnt about the complications of diabetes, you have to anticipate the complications and preempt the disease as much as possible, in which place I think SGLT2 inhibitors becomes a tough competitor to DPP-4 inhibitor. So if you ask me my first prescription for my patient, if it is going to be a patient whose HbA1c say around 7.5, maybe a dual therapy. If it's more than that, I will straight away start on a triple therapy of a metformin, SGLT2 and DPP-4 inhibitor, because number one, you have the potential to push the patient to even remission. And number two, you are going to anticipate certain complications and then preempt them. And number three, DPP-4 inhibitors, especially the verified trial, tells you that possibly you are doing something to the beta cells as well. Down the line, when the glycemic control is not sustained enough, which is the normal pattern in the type 2 diabetes mellitus, you take the participation of your staphylococcus like sulfonylureas, and maybe instead of DP4 inhibitor, in the patient population that we have identified, a GLP-1 receptor agonist or a co-agonist will be in order. So this will be my first approach to the
Correct.
patient.
I think I get your point. But how often at 7.5 you feel that we should start triple combinations?
I do it.
You do it immediately.
I do it,
really.
and then the results I tell you are rewarding. You can push the patient to 5.8. At that time, the pressure is from the patient. Doctor, my blood sugar is normalized. Do you think
Correct.
I have to scale down? Why don't you reduce some of the tablets? Which I do not succumb. I persuade them. It requires certain amount of conversation.
Okay. But there has been also some recommendations some people practice depending on the HbA1c. And I'm just telling you that you know that better than me, that the HbA1c X, say 8.4 or something, I'll give 3. If it is 7.5 below, I may give 2. But I mean, as Ram has said the platform, it is absolutely individualistic and absolutely the patient sitting in front of. Yes, Arvind?
I think I heard Dr. Ramchandran speaking about, art of diabetes beyond science, and then he very clearly mentioned, I don't think you should really be looking at the HbA1c
Correct.
any longer. I think it is just a number. If the patient is comfortable, and then is happy, and then it's not beyond 8, I think we all now tell them, okay, you just move on, you're doing well. We don't have to worry about the number.
I mean, there has been recommended.
I think I'll slightly beg to differ from Arvind for the simple reason, you have got enormous data to tell you, if in the first 6 months to 1 year of initiating therapy, you are not able to achieve the target HbA1c, your job becomes much, much more difficult. That's number one. And number two, such people are candidates for future complications. We have had that observational data in UK,
Yeah,
where
I
in the
think
first
I've
year,
seen
1 minute, let me finish.
I've seen those
So
data,
yes,
especially
you
nephropathy
do
and all
not
that.
go by the number of HbA1c, but in treatment, you should have some yardstick, some parameter.
At least
So
FBC,
the
FBS,
one that is
PPBS.
of priority is certainly your HbA1c, and of course, other aspects like the art of medicine, you always cushion
Yeah.
the molecules that are
How
very
many-
comfortable
how
to
many
the
of
patients.
Of these 4 musketeers believe that the first year control, you say 6 months, how many of you believe that the first year control matters? Krishna is here. We wrote about first year control matters. So how do you think first 6 months control matter? First year control
I
matters.
think right at the beginning, I think there is sufficient data, as
So
you very
early
rightly said.
intensive control is
Early
your
intensive
objective.
control
Hari?
definitely on a long-term benefits. But then he didn't know we were discussing about somebody who is already 72, 73, HbA1c 6, 7.6. So we are comfortable. We are talking about that.
Correct.
Undoubtedly, early good control is essential. There are enough data to say that first 5 years of diabetes life is the most important. If you can control diabetes well during the first 5 years, late diabetic complications are far less than trying to catch up with it after first 5 years are over.
Correct.
So early good control is a must.
Yeah. I think, Ram, those previous things while we were students, like we wait for 15 days, 1 month is over for long. Yes.
Absolutely. Yeah, I just want to clear up the disagreement with Arvind and Venkat. What Arvind said was misinterpreted by Venkat. What you said is that even yesterday I had a person who was 82 years. Okay, his HbA1c was 7.5. So he said, "Sir, my sugar is out of control. I should bring it down." I said, "No, your sugar is. If you are 80, your sugar HbA1c should be 8. If you are 75, 7.5. Very good, easy calculation. Don't bring it down to 6.5. You will fall in the bathroom tomorrow and you can have a fracture." That's the problem.
I think it's important. And,
Yeah.
while you were in the elderly treatment, what do you think specialty, Hari, in the treating the elderly diabetes, just for the benefit of all of us? You are the expert of the experts, Hari.
I think it is only too well known, and these are the people who insist on tighter control. The
Yes.
patient asks you, that is where the problem is.
Correct.
If you look at
But what
even the
you should do-
guidelines, even those who do not have any comorbidities at all, after age of 65, not 80, even after the age of 65, the hemoglobin A1c level 7.5 is recommended. A fasting blood sugar less than 130, a pre-dinner blood sugar less than 190.
Correct.
Older you are and other comorbidities come in, even 8% is admissible. I think elderly people you will have to be a little more gentle, also use that are not too long lasting,
Such as?
too long duration drugs. I think that's a must as far as they are concerned.
Yeah. So-
Quality of life is important than the
Absolutely
quantity of blood sugar level.
Correct. I think, Hari,
I think besides the elderly,
before that,
one parameter which probably, I think I have made a
Correct.
note and I'm sure all of you will agree, patients who get admitted for severe hypoglycemia have unrecognized CKD, and they are on board with sulfonylureas. So it's not a sulfonylurea that is the problematic, but it is the context of the disease in question. So unrecognized CKD. So as you rightly said, certainly the age of the population, that's why I said the target you identify for that individual, which has to be certainly relaxed, and then do not encourage the positioning of molecules which are more potent, which is not required at all.
Yeah, I think very well said that you have to customize depending on the person's age sitting in front of you. Give what is optimal for him, as Ram says, 7.5, 8.2. The number two is that always give the drugs which do not produce hypoglycemia, like gliptin or metformin. Whatever you think, the drugs which do not produce significant hypoglycemia, maybe those are the drugs of choice. Now, the very important question that in today's parlance and all the guidelines, there is clear-cut recommendations. You know, guidelines, Professor Mujesh, you said like railway timetable. People may come in time, but they know how much late they are. So we may or may not follow. So how many of you believe that the recommendation that you should give GLP-1 array if the patient has cardiovascular disease, you should give SGLT2 if patient has heart failure and CKD? I'll start with Venki again.
Yeah, I think the guidelines are there, but to translate the guidelines into practice, we have to be much more pragmatic, take the cost effectiveness into consideration. Couple of examples I will quote. The DPP-4 inhibitors were introduced very early, and maybe a small percentage of population we did prescribe. But once the branded generics became available, I think that was a standard prescription to start with the DPP-4 because you are able to translate the science into practice because of the cost effectiveness. So on and so forth with your SGLT2 inhibitors. Certainly the molecules are one of the wonder molecules in the therapeutic armamentarium, and once you have the branded generics, you are able to. Likewise, possibly with the GLP-1 receptor agonists, you have identified the subset of patients who are candidates, maybe the cost effectiveness prevents you or certainly dissuades you from positioning of these molecules. But more and more players in this arena, provided we have the knowledge of their efficacy and the safety,
I think absolutely
possibly.
fabulous answer. I get your answer. I agree with your answer. Now, you see, while we were in this question of affordability, which are the drugs which are most affordable today? Just for the benefit of all of us. SU, metformin, gliptin, and pioglitazone.
All of
what
them,
are the most affordable?
I think all of them, sir. Because
All
in
of them. Good.
the generic world, I think,
Yeah.
I mean, GLP-1 is available for less than 750
Yeah.
rupees
So
a
it is-
month.
so it is-
I think
it is there.
all of them are affordable because there was one patient recently who said that, no, I cannot afford a GLP-1 or a combination of an SGLT2, and then I knew he would smoke. I just asked him, what cigarettes do you smoke? He says, Gold Flake Kings. I said, each Gold Flake Kings today in Karnataka is 30 rupees. That means 2 cigarettes is 60 rupees.
General knowledge.
No.
I said, all that you'll have to do is to stop smoking one cigarette and you can afford the drugs. And then he was a driver. First he said, I can't afford it. He said, one cigarette less a day. I said, you can afford the best treatment.
While we are on this topic, I would like to ask you something which Virendra just now presented. Now, I'd just like to ask you that what Virendra is here. Virendra presented wonderfully the hyperglycemia and the treatment with the GLP-1 plus GIP combination. He presented that particular paper just now before you came. So, how many of you today start, because I'm going to the questions because it's a very free discussion. How many of you today believe that a person has, he said BMI 27, don't go for 27, even lower than 27, if the sugars are high, how many of you will start with GLP, GIP or GLP for the control of diabetes per se? If there is no obesity, significant obesity, how many of you will give it only for the diabetes?
I think had you asked this question a few weeks back, before the availability of the generic forms of GLP-1, our answer would have been probably insulin. Now at this point of time, I think you have the opportunity to exhibit these molecules because capturing the HbA1c is not a big task because the insulins are there, powerful molecules are there. But doing it with less side effects, because treatment-associated weight gain is something which you are talking about nowadays. That has to be avoided as much as possible in your pursuit of achieving the target HbA1c.
And also beyond insulin, the cardiometabolic benefit.
Absolutely. I think this class of molecules, the GLP-1 receptor agonists as well as the SGLT2, I think should be much more patronized. Given the introduction of so many players in the market, I think it should be given a please. That's my
Absolutely.
opinion, which we have already started doing, I guess.
Yeah. I think a brilliant answer. I mean, you see how the things change. We did a study for 3 years called what is it, landmark study. We found over 3 years how the practice of prescribing OADs has changed, Ram. It has changed from sulfonyl metformin to gliptins and SGLT2 that time. It's finished about 2 years back. So even now, if you repeat the study, it will be more of, as you rightly said, all the three, semaglutide, the GIP, GLP, GIP combination, all that will be used. Now, one question I want to ask you. Do you believe strongly that more than 3 sulfonyl oral drugs, more than 3, 1, 2, 3, more than 3 oral drugs should not be used? I'll start with Hari.
I think that question is a very relevant question. I wouldn't like to add more than 3 drugs. Even beyond 2 drugs, you wonder whether you should add a 3rd drug. But that has become a habit now. We do it.
Okay.
Beyond that, I think I would like to at least estimate the C-peptide and GAD65, particularly younger the patient, younger the type 2 diabetic patient, to make sure that he or she is not a LADA.
Correct.
I would like to give at least a break and go for an intermittent insulin therapy or concomitant insulin therapy and see whether we can catch the control again with 2 or 3 drugs.
Yeah, I think it's a beautiful thing that beyond 3, giving oral hypoglycemics may not be. I'm not talking about all the cases. May not be that useful. It may degrow.
Yeah, what I will do is yeah, absolutely, I agree with him. I will leave that decision to the patient. Because he's already on 3 drugs. And then they say your blood sugar is high, you may need insulin. So no, we have a problem. Patients will always say, no, I don't want insulin. So first thing is tell him, if you're not under good control, you need insulin. Tell him that, he will change. The fear of taking insulin will change his behavior. That is one thing. So I think you can use 3 or 4 drugs, but I think take the psychology of the patient who wants to start insulin or not. Yeah, Arvind.
I think if the 3 OHAs that you're talking about is metformin, SGLT2 and sulfonylurea, and then if the patient says, okay, I don't want insulin, I don't want a GLP-1, we still have pioglitazone.
Yeah.
I would still go for the 4th one.
Yeah. I get it.
Before
case,
we
I think
decide on
I fully
something
agree.
else.
We've seen
And
how
sometimes
Pi was
we
helped
forget
in control.
pioglitazone a lot.
Correct. I think it's very good.
Yeah, I think in therapeutics there is always scope for all the molecules.
Correct.
I think totally agree with Professor Hariharan and Ram. Yes, when there are 3 molecules on board, it becomes a very difficult job. But I'll give a scenario which is not uncommon. Supposing a patient's fasting is 108, postprandial is 220. He is already on board with SGLT2, DPP4 and metformin. Obviously, a DPP4 inhibitor or an imiglamin will do the job. In other words, what I'm trying to say is all the molecules do have a job, but as a blanket advice, I think benchmark will be about 2 or 3 OEGs on board.
Absolutely.
Maybe
I
these
think that's
manipulations
all. Yeah.
can be attempted in
Yeah.
individual.
What has been echoed, re-echoed in this room from this 4 people, the expert of the experts, that it is individualistic, and we cannot be restrictive to say that.
One of the things that, insulin is something which is very difficult to start. So when you talk about GLP-1 analog and injection, you tell them it is an injection, and the next sentence I say, it is not insulin, then he is ready.
Yeah, I think that's true.
Not even once a week.
yeah.
It is not insulin, but I am ready to take. If only insulin I am not ready to take. I still do not understand. As I said in the morning, they say, I don't want to take insulin. My grandfather took
Correct,
insulin and he died.
Correct. I think very correct.
So
Ram, what
there's-
you're telling is very,
So
the
there's-
psych is very important.
So there's
Psych.
one more added to this, the intelligent group nowadays, when you talk of a GLP-1, first question that they ask is that Karan Johar thing, that medicine, I don't want it.
Absolutely.
Okay, now Karan Johar has become the...
Yeah, become the synonymous with the weight loss with that people had. Now, while we're on this, just want to ask a very simple question. You have been practicing, Hari, we are practicing 50 years. Our age will be known. Doesn't matter. So, over the years, how there is a change in the approach to treatment. Let us start with, I will speak at the end because I am, Hari.
Undoubtedly, it has changed over time. If I talk about 64, 65, we had nothing but a tolbutamide and a fenformin.
Please listen to this. This will come
That
only
is
from
all.
people.
No,
Chlorpromamide
chlorpromamide
also.
was there. Tolbutamide and chlorpromamide as far as sulfonylureas are concerned. And metformin came much later.
Yes.
In fact, Professor M. Vishwanath, even yesterday somewhere I talked, he always used to write Dianyl or Uglucon and DBA கிடையாது. Feguonide.
Figonite.
That
Before
was the
DBA,
first-
TD,
that was the
Figonite
first
came.
fenformin
You might
he was
not have heard
writing.
the names. Listen for the
Feguonide.
experts.
Feguonide. That was the first fenformin he was
Correct.
writing.
I remember.
Subsequently, DBI came. He started writing DBI. And you know why it is called DBI? It was only to say that don't buy insulin.
Good one. Very good
The
one.
drug
Very
was
good
named
one.
DBA
Very good.
only for that reason. DBI, don't buy insulin. So even at that time, insulin was a taboo. I'm talking about 64.
Correct.
Slowly, of course, the other drugs started. Glyphosate came quite early, but it was not successful.
Again, it come back.
It came by the name of Minidiab. It stopped at Bombay. We did the trial in the department.
Yeah.
I remember the cover, which was the
Correct,
green
correct,
color, light
correct.
green color letter pad. That could not make a mark at all at that time. It went off.
Correct.
Glibenclamide continued like no business, nobody's business. What is more important, glibenclamide at that time was only 4 annas per tablet. And
25%.
there were
Anna, you do
people
not
who used to
25%.
buy 1,000 tablets of glibenclamide, take it and go to Singapore, sell it, have a shopping also and
Get
come
your
back.
ticket back.
Because it was not less than 5 rupees at that time in Singapore.
Professor Ashok, I think with respect to DBA, I just thought, sorry to interrupt you. In fact, after the UDP study, Tattersall quoted, Tattersall. It's a policy decision to stop penformin. One of the favorite
It was
quotes
stopped
of
earlier than
Tattersall,
absolutely.
yeah.
Yeah.
Some of the patients complained bitterly, and it was virtually impossible to capture these patients with yet another molecule that highlights the value of this particular molecule, which is much, much more powerful than your metformin, penformin. Unfortunately, we do not have it.
Yeah, yeah. And
For
it
the
also,
sake of the audiences who would like to
also
know the
you-
legacy of penformin.
Venki, you must remember, we used to write chlorphermin. Chlorpropamide plus metformin, very useful combination. It will control any amount of blood sugar after Kesidas full tin of rasgulla, you can control with chlorphermin. So,
In fact,
that's a
glibenclamide with
particular product was
Professor
the-
Ashok, glibenclamide with metformin, it was one of the brainchild of people like Professor Samgp Moses, because he said, when chlorpropamide can be combined with metformin,
Yes, exactly.
why not glibenclamide with metformin? That's how glucorid came. I'm sorry to use the brand name. This was one of the ideas presented by the clinical fraternity like
but now the
giants
changes for the gliptin and for the DP4 inhibitors, gliptins, SGLT2, and also oral GLP-1RA. Am I correct?
We are also changing with the time.
Right. Correct.
Can I say something going
Hey,
back
please,
to
please,
1989
please,
as a
please,
students
please.
and things like that?
Please.
Dr. Sam G.P. Moses used to use one combination, chlorpropamide at night, and he would use glycinase, which was glycoside. I mean, not glycoside, glipizide. And then we would ask him, we would go to the house and say, so why are you using this? இது வந்து பாருப்பா இது வந்து என்னென்ன நைட்டில் வந்து it works for 24 hours. This is like basal insulin, and then this is short acting. So for postprandial control,
Absolutely.
No, that was recommended by Tattersall.
Yeah.
A short acting and a long acting sulfonylurea.
Two
to be combined and given.
sulfonylureas, we
Just
were
as
told
short-acting
don't
is
use two
long
I think we have got the answer. Instead of giving Lantus, we are doing Lantus in the night. Sorry, we are giving Glargine in the night and
this
modifying
was
with
used.
three
This was used for
actrapid or
quite a
whatever,
long
three short
Then
acting
I
in the day.
asked
That
Chief
was being
one
done by
day,
SGPM
and Chief
by
said,
giving a long acting oral like glibenclamide and combining with short acting like 3 doses of.
Sir, I had actually
Okay,
asked
I want to
very good.
I want to ask a practical question to all of you who are treating diabetes. There are two things I want to tell. First, a new patient has come to you. He has diabetes for last 5 years. He was in Bangalore taking treatment from Dr. Arvind. He came yesterday here and he said, see, I want to continue my treatment here. So I just came to you. He's on 3 drugs. So he came to you. And I did all the blood tests for him. Blood sugar is fasting 115, postprandial 160. He's my student. And HbA1c 7. What will be your approach to him? What will you tell him?
He's asking
What,
student
will you,
first.
just because he came and gave it to you and gave you a consultation, will you change or will you not change?
Correct.
The mistake many people do, junior doctors also, is that they change. And the moment they change, next visit the HbA1c will be 9%. So please do not fight with success.
Correct. Correct. I think it's a great lesson. If
Please
patient is
do
well
not fight
controlled,
with
no
success.
need of changing anything. Absolutely correct. Good. Good.
One more thing I want to say, I don't know how much time.
Don't look at the watch.
All of us are treating diabetes. Why do you want to treat diabetes? Because we want the people to live a good life without getting complications. We are treating diabetes, we are both of us at 50 years, 45 years, 35 years.
At 10 years. Youngest.
Not 10 years, yeah, it's not 15
I'm
years.
joking, I'm joking.
He is a grandfather. He's a grandfather. You are 50 years.
So now I want to ask you
let me finish this. This is a very simple thing which happens almost all the time. Let us say, I've been treating somebody for yesterday also I saw Mr. Shanmugam. I was treating for 30 years. His son had come with him. His son, when he came first to me, he was only in 4th standard, but he's a doctor now, okay, doctor now. Now what happens to some of these patients is that they'll be coming continuously, regularly, once in next 6 months, all that. Suddenly I don't see him for the next 2 years or 3 years. Then he will come again and say, what happened? Oh, sir, you've been treating me for 20 years, but I had a heart attack. Okay, and then I went to the corporate hospital. Cardiologist said, you have to do bypass surgery, and I spent 15 lakhs. And then they told me I got myocardial infarction because of diabetes. I have been treating his diabetes for 25 years. Now, I got to tell him, he doesn't appreciate that we treated him 25 years and prevented his heart attack for 25 years.
Good.
But he paid 15 lakhs to the cardiologist. Totally for the last 25 years, he has paid me only 10,000 rupees. How much you paid me?
Good one. Good one. You see, Professor Moses had a good word for it. For these short-acting issues, he used to say, have a meal, have a pill, have a meal, have a pill. He had his own ways of saying how to popularize this molecule. Now, I just change gears because you see on the watch, Ram is hungry. Ramjita, didn't have breakfast yet. Now, the most important issue that I want to ask you is that what are the things for the Indian phenotype? Let us accept that. Indian phenotype, how does choosing a regimen for the Indian phenotype differs?
Thank you. I think very relevant question. Fortunately, the concept is there and then the data are there. Indians, Asians and Indians respond very well to DP4 inhibitors and SGLT2 inhibitors.
Yes.
So we have the science behind us to promote this molecule, upstream positioning of these molecules in the early part of the disease and continue down the line. But only thing is a good number of them do escape control. There I think the situation happens, as we rightly discussed, after 3 years. So most of type 2 diabetic subjects in the Indian context will be candidates for combination therapy, as I told earlier, with 2 or 3 drugs, maybe a third drug added sequentially or concomitantly, which I used to do for the reasons that I have already alluded to. And once then I think issues probably either supplement or substitute 1 dose of your DP4 inhibitor with an SU. Or if the control is good, certainly you can continue and then do some of the manipulations so that the postprandial is addressed. And
How many of you subscribe to the view of using this starch blockers, acarbose, other things?
I always say, classical example, fasting is 103, HbA1c is 7.3, postprandial is 220. Do the structured SMBG, all the meal related.
Use it quite a bit.
Yeah, brilliant. Because 50 to 60 milligrams comes down, your HbA1c 6.9, you're happy with 8 years or 10 years of diabetes.
So I think, Bala, we use the starch blockers freely to control the blood sugar early, definitely for the surgery and all that. My daughter who has just become MD, she says you are not targeting the root cause. You are just giving, why are you giving this drug? Do you subscribe to her? Nandita is not here, she also says the same thing.
I think probably acarbose had one of the first studies which has got MAG, cardiac protection study, in the STOP NIDDM trial. I think that will be the answer for that question.
Yes, STOP NIDDM trial, fantastic. It was done by Chagan, no Chagan. Yes, very good, very good. Now, last 2 questions. Now you see the best practice, 50 years, I told him 20 years, now I make it 25, 20 years, 50 not, 30 years, and 50 years, 50 years. How is the best practice to make a patient accept insulin? So let us listen from the horse's mouth what best practice they have. Well, I'll tell you, I asked Dr. Sheshaya one day, this question one day, he said, what I do, I show the patient when he comes to me that this is insulin, this you don't need now, but one day you may need it, it is life-saving. So that is one of the best practice he taught me. Best practice from Venki. Very short, 1 sentence.
Yeah. 1 sentence is, if he is already on board with 3 molecules, HbA1c and the fasting PP and the sugars are high, I'll tell him that insulin is the only option, but you have many choices in insulin. A fourth molecule will certainly reduce the blood sugar level, but seldom enable you to achieve the target. And sometimes, if you initiate this conversation with 10 patients, maybe 70 to 80% accept it. 2 of them might migrate from me, which I don't bother.
Doesn't matter. So you say it is mandatory today.
Yeah. Don't compromise on that.
Correct. Absolutely.
I have one very standard explanation example that I tell the patients that, look, you have a cow at home and then you need 10 liters of milk. Your cow used to give 10 liters before. Now after 7-8 years or whatever it is, your cow is giving only 6 liters.
Your pancreas.
What will your wife do? And the immediate action is, the reaction is, okay, we'll buy 4
Buy
liters.
milk. Great. His grandfather, Bhavna delivered. Yes.
One simple way of one simple way of convincing is to say, number one, see, after all, in diabetes, insulin is at fault. So the best replacement is insulin. Unfortunately, nobody likes to take insulin, so we are substituting with oral drugs. Now that is failing. You take insulin. Not only that, the sense of well-being you get with insulin, you will never get with oral tablet, especially when you are on 3 or more
Absolutely.
drugs.
That is BMJ 1984. When I arrived in the UK, the first journal I saw, it said, insulin gives you a sense of well-being.
Well-being.
Fantastic answer, Hari.
Yes.
I think the answer.
No, you say your perspective. How do you convince your
That's a secret, you see.
Good one. So, very good. You said a secret. I'll tell you a joke, It is a joke which is published yesterday. There was a husband and wife team, and husband and wife were working together in a mela. Mela means in a festival. And the wife asked the husband, if I am lost in this mela, whom will you go? Will you go to the police or you will go to my relatives? Where will you go? He said, I'll go to my guru who have recently adopted me. Why guru? He said, my aspiration, my prayer has been fulfilled. Now, so just a small digression.
Too bad.
So now the
one
question,
clinical
secret,
situation-
he's telling secret.
Yeah,
So that's why.
we'll find it during the lunchtime. So, Professor Ashok, one situation I thought we should discuss, take it for discussion is, somebody comes to me. He has already been told of having diabetic nephropathy with CKD. He is on board with 4 milligrams of glimepiride, metformin 2 grams or 1.5 grams, and full dose of sitagliptin. HbA1c 6.8, and you calculate the EGFR. Yesterday it happened, 23. He is in CKD stage 4. He is not a candidate for most of the molecules, at least in the doses that has been prescribed, and some of them are absolutely contraindicated. You try to change it. I am reviewed yesterday. Last month I saw him. His control is good. Now you undertake the exercise of giving a scientific prescription, switch him over to insulin, and maybe add an SGLT2 inhibitor, or retain the DP4 inhibitor, which is permissible, and these are very mild molecules. The control is erratic now. Now, he thinks that the control is so good with so many molecules, but here where I think your reputation, your patience, sometimes you're even questioned by the family. Why are you doing it? It was so good. I think probably some amount of consensus among us, you never compromise, because that is the wrong prescription given the CKD status, which is not uncommon.
Yeah, I think I agree with the point. Adding insulin, that point, that will be definitely seen both sides. Absolutely correct answer. Now, the last question, and very important question, is that about the various insulin regimens in type 2 diabetes. That was the topic for giving today. How many of you use Basal Plus?
Straight away, no. I think I would still start with basal and then basal plus if I require the prandial control. So, we have an insulin which can take care of both, but not as the first insulin. We still start with the basal and then the basal plus.
Yeah.
Very few cases we may use Rizodax straight away to start.
How many basal bolus you have, Benki?
I don't have much, but the co-formulation of a glargine with Lixi, I am using a lot, because you have the advantage of addressing the meal-related excursions. Yeah. That has found handy, but you don't have much of a weight loss. It's fairly weight neutral, but you have the advantage of the targeting the fasting and the so the first injectable space could be a co-formulation of a.
I think what Benki is telling is correct. That in the sense, you the benefit of a GLP-1 array, maybe small quantity, but get a benefit of that along with the best of insulin. Correct.
Basal plus oral hypoglycemic agent. No
That's
doubt.
best. That's
Basal
called BIDS.
plus I do not.
BIDS. Basal insulin plus daytime. Sulfonylurea is not sulfonylurea for oral drugs. So that's a That is the highest, in that I-7 India study, we found the maximum number of people in our country are on one injection and rest rest on the oral drugs. That's the best combination that we have.
Failing which I go on
Absolutely.
mixed, pre-mixed.
Ram?
Absolutely, it's absolutely individualized. When I see a patient who's got a higher fasting, I already start with the basal only at bedtime. Very easy for them to start, and then just wait for a while. When you bring down the fasting, and then the oral hypoglycemic agents will take care of the postprandial, etc. If that's still not okay, then we'll go for a pre-mixed one in the morning, like
Correct.
what is that, a rice or
Yeah, I think that's a good, important question. Still, mix is used in our setup, and it has served many purposes for us because we do not have a team, so we do not have a lot of laboratory tests, and we want to give convenient drugs, which is patient education not necessary. So the pre-mix insulin is still in our country, and it has also come back. Recently, I saw an article. It has come back in a new avatars, and people are using it. And in one of the conference, which is, they talked about the classics, the diabetes treatment drug, the classics. In the classics, that drug featured along with metformin and SU. Dear friends, the main part of the meeting is over, but the main part is there on you. Now, roast the experts. You have to ask one by one question. One question must be very short. Each person takes one question and not very long question, and answer must be short. And we'll have only 5 to 7 minutes. Yes. Yes. Okay. Very short question.
Sir, chlorpropamide was introduced very long back. It has got 36 hours of half-life. At the beginning, it was tolbutamide, then subsequently came glibenclamide. So that was the history the long back. And DBI was there, I have used DBI. Chlorpropamide, I have used it. I have used all these molecules. My simple question is, we are talking all about diabetes where the HbA1c escalated to 6.4 to 6.5. My simple question is pre-diabetes or early diabetes where the HbA1c starts from 5.7 to 6.4. And we know very well, the learned pundits have seen what all the atrocities and the bad things which can done by the pre-diabetes, because diabetic retinopathy is 126. We see a lot of diabetic nephropathy in the early stages. Why not you start SGLT2 in this stage when the patient has got some mild symptoms, not grossly. BM is 24.5, his lipids are just in the border range. That's all. So I want your expert opinion.
I think Ram is the expert on pre-diabetes. Ram and Arvind.
If it is going to be CKD, even without diabetes, you've got indication. Use it CKD.
Yes. I think it's a wonderful drug to be used more and more. Agree.
Yeah.
I agree with
So, CKD, even in the absence of diabetes, is a indication for patronizing SGLT2 inhibitors.
USCS 33. I'm not telling 300.
No, you said CKD.
Okay,
That's why
I think one person, one question, one answer only. Yuvraj.
Sir, one patient for the past 30 years non-diabetic. He was on glycinase and metformin. Good glycemic, good control is there, no complication. Age is 65, nearing 70. Can we change the tablet to the latest molecule? Everything is normal. HbA1 is normal.
Somebody is on the combination of metformin, sulfonylurea, and why change? What Ram told the principle.
Yes.
If something going good, don't disturb it.
Dr. Ramchandran has already answered
Not only don't change the molecule, please don't change the brand also.
Brand also. Yes.
Good. Very good. Next question.
Thank you.
Next question. Please ask Gauri Shankar, of IIT fame. I'm very afraid of IIT people. He has already told me, sir, 1.5 minutes left. Gauri Shankar, my friend from IIT, he said that only 1.5 minutes left for this session, or the lunch will be taken away by the Russians.
Comment on chlorpropamide when he said about chlorpropamide.
Yes.
One Dr. Ship,
Ah.
he used to say it
J.C.
is an
Ship.
oral pump.
He was with him.
Yeah, that's why I'm saying. He described chlorpropamide as the oral pump.
Oral. Acha.
Oral pump.
Acha. Good. Capson. This is a wonderful drug. I'm missing it. Definitely. Really?
You can still get it.
I see.
Both tolbutamide and chlorpropamide.
No, I don't
if you
want
want
tol.
to prescribe,
Not all, only chlor.
if you want to prescribe, you can still get it. There is a Madurai-based company which markets it.
Good. Any other questions from the audience? If not, it's our great duty and opportunity to thank this godly quartet, comprising of Venki, Arvind, Hari, and Ram. And I think it was a very informal discussion, full of love and full of. No, it is great. So it should be like this. The knowledge was dissipated within that. I think you must have got some benefit. Something must have told, and at least seeing these people, that we're in the correct track. Thank you very much. Bye bye.